welcome everyone to the eMedica MRCGP SCA Study Club for October 2025. For those that haven't met me before, a brief introduction. My name is Muhibbur Rahman. I'm a portfolio GP based here in Birmingham and Solihull and a consultant in medical education. I used to be an examiner for the GMC. I sit on the NICE GP reference panel. I did GP training in Neath Port Talbot in South Wales, passed my MRCGP with merit, and I did the CSA, which was a precursor of the RCA and then SCA back in 2007. I was involved in piloting it in 2006. And our team at eMedica have now trained over 83,000 delegates. So for those of you, I can see some names, people that have been to some of our previous study clubs, some are coming for the first time. So let me just explain the format. We're going to go through a sample SCA role play. In fact, today we're going to do sort of two smaller part role plays. And so it's interactive. Try to get involved. You can use the chat to get involved, to pass comments, to get involved in the discussion about the consultations. If you've got a question that you'd like myself or the faculty to answer, use the Q&A for that. And joining me as part of the faculty from the core eMedica team, I have Anna Greathead this evening. So we'll start by going through two SCA role plays. They're actually the same patient, two different consultations that we're going to look at. Okay, and then I'll discuss key learning points. We'll review some of the relevant changes in the NICE guidelines relating to this topic, and then we'll finish with talking about useful resources and support that we offer for SCA if you're preparing. And we've got a Q&A at the end. You can ask anything that you'd like. Ask that in the Q&A, not in the chat. Okay, let's start. I'm going to give you some time to have a look at the patient information, and then for those that went before to one of these things, the way we do this is the simulator will come online. I'm going to be the doctor, but I'm going to ask questions on your behalf based on what you type in the chat. Okay, so I'll leave that on for now. I'll give you a chance to have a look at it. We'll type this information into the chat and pin it so that hopefully you can refer back to it if you need to. But once we actually start the consultation, I'll turn the screen share off so that you can actually focus on the simulator. Okay, so I'll give you a minute or two to have a look at that. In the real exam, you get up to 3 minutes to read the patient information before the patient appears. Okay, everyone had a chance to look at the information? Okay, we have posted it into the chat. I'm going to stop the screen share now so you can actually focus on myself and the patient. I'll get the simulator to come on because it's a remote video. Okay, so just to recap, I'm going to ask the questions on your behalf based on exactly what you type into the chat. So please type it exactly the way that you'd like me to ask it. I will just do the introduction and then I'm going to wait for you to ask questions. So let me stop the share so you can hopefully see myself and the patient. And we'll begin. Hi, is that Jenny Carter?
Yes, it is.
My name's Dr. Rahman. I'm one of the GPs here. How can I help today?
I'm really sorry. I'm going to be wasting your time.
Okay, so I'm going to wait for you guys to type things in the chat. And what would you like me to say? That's what I'm going to say. So the more you get involved, the more that we can progress the consultation. So I'm waiting because no one so far has put anything. It's not a waste of time. We're here to help you. So what can I help with today?
I've just had a funny tummy recently.
Can you tell me a bit more? What do you mean, funny tummy?
Well, I'm just going to the toilet a lot more than I used to.
Since when has that been happening?
It started about a week before my daughter's wedding, which was in the middle of August, so about 2 months.
Right. And have you noticed any blood in your stools?
Oh, no, nothing like that, no.
And when you go to the toilet, what are the changes? Is it sort of loose? Is it hard?
Oh, it's much looser than usual.
Right. Any mucus?
I don't think so. I don't know if I'd recognize that.
Okay. Any weight loss?
No, not that I've noticed.
And how has this been affecting you?
Um, there's a couple of times where it's been inconvenient. I've really had to rush to find somewhere to go to the toilet.
Right. And what's been going through your mind?
Well, I think probably, obviously, it was stressful organising my daughter's wedding, and I think I got a bit stressed then, and my body just hasn't clicked back into normality.
I can see this is really having an impact on you. And do you feel bloated at all?
No, you mean like when after you eat and you feel very full like that?
Yeah, or like sometimes if you feel like there's wind trapped and you feel like your sort of stomach just feels a little bit uncomfortable and full.
Maybe a little bit every now and again, but not much.
Okay. Um, have you had any tummy pain?
As I say, just a little bit, but it's quite mild. And I just thought it's because I'm going to the toilet all the time.
Have you felt sick at all?
No.
And do you think that you said it's been a couple of months? Do you think it's getting worse, getting better, or staying about the same?
It feels like it's worse when I'm at work because it's hard to get to the toilet, but I think it's probably staying much the same.
Have you had any vomiting at all?
No.
No. And how many times a day would you have to go?
Maybe four, typically.
Right. And you mentioned that you had a wedding that you were organizing for your
Mm.
daughter. Was that any recent travel associated with that? Was that,
Oh, it was local.
oh,
So
okay. Any problems with eating or drinking?
no, no.
Right. And you mentioned that, you have to go more, but also sometimes you really have to go quickly. Have you had any incontinence? Any
You mean
accident?
where I don't get there in time. It's there's a couple of times where it's been near, but I've always managed to get to the toilet, thankfully.
Okay. And is there anyone else, in the household that's had similar issues?
No, it's only my husband and I at home now.
Okay. Have you had anything like this before?
No, no, I'm usually fit as a fiddle. That's why I feel like, wasting your time being here because it seems quite a small thing.
And I mean, you mentioned that you thought it could be because it's been stressful with the wedding
Mm.
and so on. Um, did you have any worries about any other thing or any other way?
What about any other stresses apart from the wedding?
Yeah, or that this could be anything other than stress.
Well, no, I didn't. I've only come here because my sister insisted. She said it was going on too long and I should come and see a doctor.
Okay. Um, and any change to your diet recently?
No, no, I think I have quite a good diet.
Okay. And have you noticed, like, if you have specific types of food, that it's more likely to happen, like spicy food, or if you have something different than like if you have a takeout, for example?
Oh, we don't do takeaways. But no, I've not noticed anything particular. No,
Okay. And in your appetite, is that changed?
no, no, that's fine.
Bit of a strange question, but have you noticed any change in the character of the stool? Like, is it darker or
Um, it's much looser than usual.
much looser? But apart from
Yeah.
that, it's not like change color, it's not black.
Not that, no, it's not, yeah, no, it's
Okay.
just dark, it's just looser.
Have you had any temperature, fevers?
Not that I've noticed, no.
And you mentioned you do have some tummy pain. Does it have any relationship to eating?
I'd say more I get a bit of tummy pain just before I need to go into the toilet. But it's not bad. It gets, so it's manageable.
Okay. Any family members with any bowel problems?
No.
Okay. Um, anyone in the family who's had breast cancer or ovarian cancer?
Cancer? No. No, not apart from like distant relatives or elderly relatives, things like that.
Okay. Have you had any history of having thyroid problems in the
No,
past?
as I say, I've always been fit as a fiddle. I don't really see the doctor very often.
Okay. And were you hoping for anything particular from disappointment today?
Well, I was. It's difficult to say. As I say, I've come because my sister said that I ought to get checked out. So it would be good if it could get sorted because it is a bit inconvenient.
Okay. Um, do you drink any alcohol?
Um, we go out for dinner maybe twice a month, and I might have a glass of wine then. But we never have any alcohol at home.
Okay. I'm asking because sometimes some lifestyle factors can affect bowel.
Okay, yeah, fair enough.
Like similarly, smoking can have an impact. Did you smoke at all?
No, never.
No. Okay. Um, can I ask if you're working at the moment?
Yes, I am. Yeah.
What do you do for work?
I'm a delivery driver for Amazon.
Okay. And is that like new? Has there been any change recently in your sort of work?
I used to manage a hotel, but that all went pear-shaped during the pandemic. So since then, I've been delivery driving. So it's been 5 years now.
Okay. Right. So I'm going to pause it there. Jenny, I'm going to come back to you in a minute. I'm going to just share my screen again. So just a reminder of the information we had about the patient. Okay. This is what we know before they've come in. 52 years old, 2 live births, 1 stillbirth. Smears all on time. Last one was clear 2 years ago. Breast cancer screening 6 months ago. That was clear. And bowel screening, QFIT was negative 18 months ago, and nothing else of note. She said she's normally fit into the fiddle. You can see no regular prescriptions, not been seen at all recently. The last one was just the breast cancer screening. So that wouldn't be in here anyway. It would have been handled by the screening program. Okay, so we've asked lots of useful questions. We've got quite a lot of information, but let me just look at some of the things that perhaps we could add. So I'll just look at what we've already got so far. Because she said her bowels are all over the place, that can mean lots of different things. And something that was really nice is right at the beginning, she gives this opening line that, I'm sort of wasting time. And it's really easy to not acknowledge that and not refute it and just ask what could be a sensible question. Someone might just ask, well, tell me more about your bowel. But what was really nice is that, lots of you put in, you're not wasting my time at all. And this is really important. Sometimes patients, they'll say something like this, and if you don't acknowledge it and refute it and instead just ask a question, what do you think can happen? What do you think could go through their mind? It could go through their mind that you agree that while you've not actually said it, but that you're bothering them in some way, and next time they get something similar or get a different symptom, they might feel, oh, I don't want to waste a doctor's time. So it's really important to actively refute it. And so that was really nice. Lots of people said, look, not at all. We're here to help. You're not wasting my time at all. Something like that's really, really important at the beginning. Okay, so well done on that. So look, we want to find out how long has it been going? So it's been a couple of months. How often is she going? Does she have pain? Bit more detail perhaps on the description of the pain, exactly where it is. If there's radiation, might be helpful. If there's bloating, the consistency of the stool, urgency, incomplete feeling of emptying. Something that we didn't really get much detail about, while we did ask about smoking and alcohol, is the diet. So fiber intake, caffeine, fluids. Has she tried anything so far, whether it's over the counter or a herbal remedy? We did ask about family history, so that's good. Let's think now about some of the specific questions that will help us rule out less common but more serious things. So people asked about weight loss or weight changes. People asked about appetite loss. Those are two really, really good questions. Okay. The other really important ones, if we look at the guideline, would be to ask specifically about rectal bleeding. So we did ask if there's any change and if she's noticed any blood. Perhaps you could just get a bit more detail about that. Have you noticed any blood when you wipe, for example? Because sometimes there might not be blood mixed in with the stool. There might not be a change in color, but there might be a little bit when they wipe that can tell us that it's more likely to be rectal or anal pathology rather than something, further up the bowel. And then one of the things that sometimes can be useful is if we get bloods and we see that there's iron deficiency anemia, that can give us a clue that they've had blood loss going on for some time, right? What are some of the symptoms of that we could ask about? Because, at this stage, we might do some blood. We'll come on to that in a minute. But how could we check for that by asking the patient questions? What would be some useful questions to ask? Yeah, so you could ask about if they feel more tired, if they've had any periods where they get out of breath, if they find that they can't do as much in terms of exercise tolerance, if they get dizzy at all. Some of these are really useful clues that someone might have anemia. It could be for any cause, but that would be one of the things we'll be thinking about. All right, okay. So let's just recap some of the information we've got, and we'll talk about then what we might do in terms of the next stages. So what we've got this patient with about 2-month history, so about 8-week history of altered bowel habit, that they've got more loose stools, going more often, having urgency, but without any rectal bleeding, without any blood mixed into the stool, no symptoms of iron deficiency. Had we asked that, she's not been feeling tired, she's not been breathless, she's not had a reduction in exercise tolerance. And we didn't explore the diet, but she's got a good diet, okay? She has a decent amount of fiber, she has a good mix of different things, okay? Now, you're never going to examine anyone in SCA, but these sessions are beyond just exams. I want you to think about, what if you had this patient come to see you in practice? What would be relevant examinations to think about? And in SCA, sometimes they will give you examination findings in the information that you look at before the patient comes in. Sometimes they'll say, "Oh, was seen for this, and these examination findings were noted," where it might be relevant. Here, if you felt examination was really important, one of the things as part of your management might be to ask them to come in, right? But what examination would you like to do for a patient like this? We'd want to check things like, the most important thing would be they've got bowel-related symptoms, is to do an abdominal exam, perhaps a digital rectal examination. You could look at the sclera to see if they've got pallor, if there's any jaundice. These kind of things would be useful. And then a more subtle one is just things like checking blood pressure, looking for if they've got any generalized lymphadenopathy. Things like that can be quite useful. Okay, so looking for masses, looking for pallor, that kind of thing would be useful. All right, so we haven't got examination findings because they're not with us yet. Based on the remote consultation, from what we've already picked up, what could be the diagnosis? What would be going through your mind? Type into the chat. What's in your differential? So someone suggested it could be IBS or IBD, so irritable bowel syndrome or inflammatory bowel disease. A couple of other people have said that we need to think about bowel cancer. And certainly that would be one of the really important things to think about, right? A couple of people have said that it could be ovarian pathology. So if you're thinking about that, what might be other useful questions to ask? Because we asked a lot of bowel-related symptoms, but what else might we ask? We might ask about menstrual symptoms, if there's been any change, any PV bleeding. Because remember, her smears were okay. She was up to date with that, but that was some time ago. Okay. All right. So how are we going to progress this? Any thoughts on management for this patient? Are you going to order any tests? Are you going to, what would you suggest could be a possibility when you're trying to talk to the patient? So maybe asking them to come in so you could do an abdominal examination. Some people have suggested maybe requesting a pelvic ultrasound, doing some bloods, full blood count, thyroid function, U's and E's. Someone suggested a stool culture. Some people have said thinking about calprotectin, CA125. Okay. So really what we need to think about, given the symptoms, we need to think about the possibility of colorectal cancer. And so in terms of investigation, actually the appropriate management will be to think about arranging a Q-fit, but you could also arrange, those bloods, and as part of that, look for an FBC, check iron levels, look at ferritin, things like that. And I think one of the things that really, really important, we already talked about, that picking up on those cues, that when she says, "I shouldn't be wasting your time with this." And then we didn't go into the diet, but one thing, while she'd had generally fairly balanced diet, one thing is that specifically, had you explored that, one of the cues she would have been giving you is that, she knows she should be eating more fruit. And we could have explored that, but we didn't ask about that. In terms of safety netting, things to think about, making sure if they get any bleeding, whether that's perectal or pervaginal bleeding, that it's important they let us know, and to be aware of the signs of obstruction or perforation. So if they get really bad stomach pain, if it gets rigid, if they find that movement makes it worse, or if they get bloating or they're vomiting, any of those things we'd be really worried about. So right, let's now fast forward to, we've sent this patient off for a Q-fit, for some bloods, and we're going to see this patient now when the results have come. So this is the second part, if you like. And what I'm going to do is I'm going to ask for a volunteer, because the patient's going to come in now and want to know about her results, because she's had the bloods, okay? She came in, had an examination, had the bloods, okay? So you can see, look, we already had this information before. She was seen a week ago. We brought her in. Abdominal mass was not found on examination. We ordered the Q-fit, and these are the results. So the ferritin's come back at 120, Q-fit's come back at 45, right? So have a look at that. I'll give you a minute or so to think about it. And I'd like to ask a volunteer to have a go explaining the results, and maybe think about explaining the next steps that you think are appropriate to the patient, okay? And then I'll give you some feedback, and we'll talk through the key things to think about. So if you'd like to volunteer, use the raise hand feature. And then what I'll do is I'll ask you to become a panelist. That will allow you to turn your camera on. Okay, so I'll give you a minute to have a look at that. And anyone that would like to have a go, use the raise hand feature. Or if you want to just explain it without coming on video, if you just want to use audio, that's fine too. So I've just stopped the share so that we can actually, focus on the patient and whoever's going to have a go. So can I have a volunteer? Some of you are going to sit this exam soon, all right? Here you've got a chance to have a go. We'll give you some feedback. It's a supportive environment. In the exam, it's going to be recorded, and then you either pass or fail based on how you get marked, right? So there we are. So Mustafa, would you like to? I'll just ask you to put your mic on for now, but would you like to put your video on, and I'll put you to panelists, or do you want to just use audio? It's up to you.
Thank you, Dr. Mahibur. I will stay without a video, if that's all right.
Yeah, no problem at all.
Yes.
Okay, that's good. So I'll call the patient in, then I'll turn my video on. So the patient's going to come back, and we've pasted into the chat, in case you want to have a look again, the details of the results, okay? The main things are that the ferritin was 120 and the Q-fit is 45, and the patient's going to sort of ask you for the results and will allow you to take it from there, okay?
Good afternoon, Ms. Carter. My name is Mustafa Alwan. I'm one of the GPs.
Hi.
Hi. So I believe we had a conversation almost a week ago over the phone about your worries about your bowel motion changes, and we ordered some blood tests, and we ordered some stool tests as well.
Yes, I think the receptionist said I had to come in and talk about the results.
Okay. How much do you know about the results? Is there anything specifically that you want to discuss before I go any further?
I was surprised that I even had to have tests, and I thought that the doctor would wave me away.
How do you feel about that?
Well, now I've had the test, I'd like to know the results.
All right. Okay. I walk you through the results, and I'll just please feel free to interrupt me or ask me any questions during my explanation, if that's all right.
Okay, that's fine.
So we've done an examination. The examination was unremarkable, but the blood test is showing two things that really stood out to me. One of them is a protein called ferritin. This is protein that is usually carries the iron particles. However, as a protein, it will become slightly high. It will become high in some cases such as an inflammation is going on. That's the first thing. It doesn't tell us much, but it's tell us that there is an inflammation going on. An inflammation could be an infection, or could be something that is a bit more serious.
Okay.
The other one that kind of really stood out to me is that the stool test that we've done, it was called the QFIT test, which what we call highly sensitive to any bleeding in the gut, came back positive. And
So it came back, it was a good result.
positive as in mean that it showed some kind of elevated particles or broken down blood in the stool, meaning that there is a possibility or higher possibility that there is a bleeding inside the gut. Would you like to know more about this?
But I've not seen any bleeding at all. I've not seen any blood or anything red or anything.
You're absolutely right. But not always the blood is visible. Sometimes it's visible, sometimes it's invisible. And this is what we call in medicine occult bleeding. That is not like hidden from the patient or hidden from sight. So that's why we use this chemical test to detect any bleeding that is hidden from sight.
Okay, so there's some blood in when I go to the toilet, there's some blood there.
Yes.
Okay.
Not visible though.
Yeah.
What that means that I have a low threshold to send you to be assessed further by a specialty. They're called gastroenterology. They specialize in the health of the gut and to have a further assessment for any serious issues. Would you like to know more about this?
Well, I thought that because there wasn't any blood, that it couldn't be cancer, and now you're telling me that there is blood, so that's made me feel a bit anxious.
I'm sorry if you feel that way, and I'll try my best to explain it further, and if that's okay with you. So basically, as I mentioned before, is that like some of the blood is seen, some of the particles of the broken blood is unseen in the stool. So what is happening is that we chemically test the stool for blood, and that indicates that there is possibly a source of a bleeding, but it's hidden from sight. What that tells us, it might be some kind of like a growth inside the gut, possibly a growth, or not 100% sure until you have a further assessment with the gastroenterology team or the gut specialty team. This is usually called a 2-week wait pathway. Would you like to know more about this?
So I have to go and see a different doctor at the hospital?
Yes.
Okay, and they're looking for where the blood is coming from.
Exactly.
Okay. I mean, does it have? I mean, how important is it? Is it just a precaution, or is it important?
I think. Well, I should tell you that the referral should be done today. It's a written referral. It should be done today.
Sorry, I've got to go to hospital today.
No. The referral should be done today. You will be contacted to be seen within a week, and we have a diagnosis within 2 weeks.
Okay.
Within the second week, yes.
I mean, do you know when I'll have to go to hospital, or will they just tell me that later?
You should be contacted within this week, most likely.
Will I have to take time off work for that?
I would suggest that you take some time off work if you have been given a date and time for the assessment.
Okay. Thank you very much. I'll stop you there. Thank you very much, Mustafa, for volunteering, and well done. Okay, so I'll just go through some feedback, and then I'm going to ask someone else to volunteer to do the next part, which will be to explain what's going to happen when she gets to the hospital. So I'd like someone to, to speed things along, use the raise hand so you're ready to go after I've given Mustafa some. So Mustafa, first of all, as I said, thank you for volunteering, because we were waiting for some time, and it's good that you've had a go. So things that you did well, I think it's good that you recognized that it's important to explain a little bit about what's been found. So there were two things, like you mentioned. There was the ferritin and then the Q-fit. And you also sort of saw a little bit about what does she know. So when you mentioned, for example, a 2-week wait, you asked that, would you like to know more? So if you like, you're telling her one bit, getting her permission to move on to the next bit. That's also good. You explained what you found and what the next steps are, i.e. that she needs to go to hospital, she needs to see a different team, she's going to need more tests to look at where the bleeding has come from. So I think all of that's important. And you also highlighted the importance of going, and that it is urgent, it is important to go, that you're going to make the referral today, but that she should be seen soon. A couple of things to improve. So you used quite a lot of technical terms, terms that might be not clear to some patients. So for example, talking about ferritin and that it's a type of protein, they probably don't need to know that. And her blood, the ferritin level was actually within the normal range. All right. So for women up to about anywhere from 10 to about 300 is okay. For men, slightly different range, but this would fall for male or female, it would be within the normal range. The bit that is important is the Q-fit. And here, again, one of the things you can see that can happen is when you said that it's positive, the patient thought, okay, that's a good thing, right? Positive sounds like a tick. Positive, good, right? Sometimes positive doesn't mean that, but it's not so much just positive or negative. Perhaps a clearer way to help understand this is, look, we looked at 2 tests. One was looking at sort of iron levels, and sometimes that can give us a clue of different things going on. One of the things it can give us a clue to is if someone's lost a lot of blood. Okay. It can also be more general, like you mentioned. It could be just a sign that there's some inflammation or other things going on. The more important one was, do you remember that we did the test where, based on your stool sample? And what that was looking at are the very tiny bits of blood that you can't see, because you said you haven't seen any blood, that is picked up by the microscope, at a very small level. And there's a certain level, if it's anything above that level, one of the things we worry about is, could there be a more serious cause of that bleeding? And then you could pause, and then the patient would generally say, well, more serious like what? Well, worst case, what we try to rule out is something as serious as cancer. Okay. And she actually mentioned, well, I thought there was no blood, so I didn't think about things like cancer, but now you're telling me there is blood. She's given you an in there because she's mentioned that word. And perhaps then just to clarify, well, actually, anything above a level of 10, we worry that it could be there. Yours was more than 4 times that, hers was 45. All right. She's above the threshold to at least have a test. It's really important. We're not saying you've got cancer. What we're saying is that there's a very small amount of blood that's been picked up, and one of the things that could cause it is cancer. The way we'll know that is for you to see the specialist in hospital, and that they can actually look inside the bowel to see, can they find what's causing the bleeding? And, the really important test that you'd need to have, and that's, you could then explain colonoscopy, because that would be the next step, right? If someone's Q-fit's above 10, you'd refer them under, like you mentioned, a 2-week wait, so that they can have a colonoscopy and biopsy, so that we can get diagnosis. One other really small thing just to be aware of, you mentioned that with the 2-week wait, that within 2 weeks, she'll have the diagnosis. She'll get the appointment, hopefully fairly soon. You're going to send a referral today. That's not quite what it is. It's that they would get the first appointment within 2 weeks, that the diagnosis should either be ruled in or ruled out within 28 days. That's what the sort of the target, if you like, or the guideline is. Okay, so some things that you did really well, a few things that you could tweak, and perhaps think about language that might be clearer for the patient to understand to make that be easier. So I'm going to get another volunteer. If I can have a volunteer to have a go at explaining colonoscopy, because that will be the next thing for this patient, right? And then we'll talk about the guideline, wrap up, I'll take questions and talk to you about useful resources. You're welcome, Mustafa, and thank you again for volunteering. So can I have another volunteer? So, Sidra, would you like to put your video on or just use audio?
I would rather just use audio if that's okay.
No problem. Thank you so much. So I'll get the patient back up and perhaps we'll just go from that she wants to know what is a colonoscopy. So perhaps you've explained that the next step would be to, have this, and she's going to ask that question and we'll take it from there.
I'm sorry, you said a colon something else?
Yeah, so it's a colonoscopy. Have you heard of that before?
Probably on TV shows, but I have no idea what it means.
Sure. So a colonoscopy is essentially a camera test, and what it involves is the doctors, they pass like a very small, thin, flexible tube. It's slightly bigger than the size of your thumb, and it's gently passed into the back passage, and it's for the doctors to have a look inside the bowels.
Okay, that sounds unpleasant.
Yeah, I totally appreciate that. It can be a bit daunting and patients can be a bit scared of it. But let me reassure you that you'll be looked after and there are medications available which will make it more comfortable for you and they can make you feel more relaxed and sleepy.
Okay, and is it painful?
So it shouldn't be really painful, but it is a bit uncomfortable. But there are medications that can help with the pain. But at any time, if you are feeling uncomfortable or you are in pain, you can just put your hands up and they can stop the procedure. So that's always an option.
Okay, and how long will it take?
So the whole procedure, the procedure itself is relatively quick and it doesn't take more than half an hour. So it's a day case procedure, so you'll be in and out of the hospital within the same day. So how does this sound to you?
Uh, yeah, I mean, if I need to have the test for my health, I suppose I'm just a bit concerned about taking time off work, and
Sure.
obviously it sounds a bit of a it doesn't sound like a very pleasant test.
No, I do appreciate that. Yeah.
Do I need to do anything to be ready for it?
Yeah, so what you normally do is you take what we call a bowel prep. So these are laxatives just to get your bowels empty for the camera test. So I'm more than happy to send you this information as well via text so you can have a read and take the laxatives.
I feel like laxatives are the last thing I need at the moment, given that I'm going to the toilet so often and
Yeah.
I'm very loose.
No, I do appreciate that. And that's what some patients do think that if we're already having loose bowel motions, why are we taking more laxatives? But it's just for the camera test in order to see the lining of your bowel and to see if there is any sort of inflammation. We need to clear your gut out first. So that's why the laxative is really, really important that we do this effectively. Otherwise, we can't see inside your bowels.
Okay, all right, then you're the experts. So this will happen in the next couple of weeks.
Yeah. So hopefully it should happen within the next 2 to 3 weeks. If you don't get any sort of appointment time, then please do let us know. And like I said, this can be quite daunting. So please feel free to take any family member with you to support you as well.
Okay.
I'll stop you there. Thank you very much, Jenny. Thank you very much, Sidra. I think you gave a good, clear explanation of what to happen. A lot of reassurance. Supportive. Highlighted that she can ask questions, that she can take someone with her, but also acknowledge that because they will usually offer sedatives, it isn't generally painful, but it can be very uncomfortable. I think one of the things that was really nice that you said that they will normally give you the opportunity that if you feel it's too uncomfortable, you can ask them to stop at any point. And that's really important because sometimes people feel I'm already there and they are feeling uncomfortable and they think, I don't want to waste people's time. Remember, this lady was even feeling like she's wasting time coming to see us. Imagine she's got there, they're already prepped, you're in theatre, they're doing it. They might feel, I don't want to feel like it wasn't a good use of time. Everyone's here now. But, if you're really uncomfortable, they're not going to continue. They'll stop if you want them to stop. Okay. So let's talk a little bit more about that. Let me share the screen and we'll talk a little bit more about the details of the management and then just recap the guidelines. So in terms of clinical management and complexity, so in terms of interpreting the result, we talked about that the ferritin was normal, but the QFIT is raised. Remember, the threshold is 10, and it's important to differentiate. The threshold for screening is much higher, but you're screening people who are asymptomatic. When people have got symptoms, it has a very low threshold to need further investigation. So that's why it's 10. So, giving a clear explanation, addressing any fears they've got, any misconceptions that they've got, explaining what a colonoscopy is. I'll come on to that in a minute. But also safety netting, that even though their appointment might be in a couple of weeks, before that, if they get visible bleeding, if they get any signs of obstruction or perforation, they need to let you know, because someone who has got bowel cancer, if it progresses, they could go into obstruction and they need an acute admission, because otherwise they might think, well, I'm going to be seeing it in only a week or 10 days anyway. I don't want to bother anyone. And then, that obstruction could turn to perforation and that could be deadly. Okay, so that'd be really important that they're aware of that. Just to recap QFIT, okay, so it's quantitative fecal immunochemical testing, very sensitive for microscopic levels of blood. And the threshold in terms of when we would refer to have a colonoscopy and biopsy or CT colonography to confirm will be 10 micrograms of hemoglobin per gram of feces. Remember that QFIT is not diagnostic. It is a screening tool. But when we're using it to screen someone who's asymptomatic, it's a much higher threshold before we refer. When they're symptomatic, as a screening tool, much lower threshold, just 10. Anything above that, we want to refer to get the diagnosis. That's going to come from the colonoscopy or colonography. So if we recap the guidelines, so first of all, what if someone had lower GI, rectal or anal symptoms? So the guideline is refer without testing if you think, you pick up a rectal or anal mass when you do that digital rectal examination, or they've got unexplained anal ulceration. And for patients who, let's say you ask the patient to have a QFIT and they'd come with symptoms that were worrying, and people don't like to do fecal-based tests, there's a delay, then don't feel like, if you've still got clinical concern, still send that referral out, okay? And the other thing is that if they had normal bowel screening results, remember this patient had a normal result, we'll go back, from screening some time ago, that doesn't mean that they couldn't have got symptoms in between. That's the whole point of screening, is it happens periodically in between. If they've got symptoms, we want to see them, okay? And we should offer QFIT to any adult with an abdominal mass or a significant change in bowel habit, or we pick up iron deficiency anemia, or if they're 40 plus, weight loss and abdo pain, 50 plus with rectal bleeding or abdo pain or weight loss, under 50, rectal bleeding and abdo pain or weight loss, so either one. They've got to have this one and then either one of these, or 60 plus with anemia, regardless of if it's iron deficiency anemia or not. So for this patient, the fact that she'd had significant change in bowel habit had been going on for 2 months. That's why we wanted to offer that QFIT, okay? And then colonoscopy. So key things that people need to understand, really, what happens before, during, and after. So the bowel prep is really important. So they should go onto a low-fiber diet for a couple of weeks beforehand. They're going to have strong laxatives, usually the day before, if it's going to be a morning test, or the morning of, and often it'll be a bit of both. So you'll have some bowel prep the night before, and then the morning of, you'll have another last one. No solid foods at all on the day, just clear liquids. You can just have water. And then generally, I always recommend patients that go for the sedation option, because some patients think, oh, I'll just have the pain relief. Often you'll have a bit of both, but it can be really, really uncomfortable otherwise. And what they'll do is they'll get them to lie on a side. They're passing a flexible tube with a tiny camera on the end. It'll be passed via the rectum. And then, like you mentioned, it takes about half an hour, sometimes a bit longer. And what they're doing is basically, they're looking to see, can they see anything that looks worrying, anything that looks a little bit abnormal? Do they see any growth? some of the things that, patients might give us cues on, and some of the ways that we might show empathy towards that. So people already did this, that I can see this is really worrying you. It's natural to feel anxious, or, we're here to support you. That was a really nice touch there. And you also offered support in terms of, you might find it helpful to take a family member with you. Managing uncertainty. There could be other reasons why it could be raised, right? Sometimes it could be something non-cancerous. Someone could have polyps, they could have piles. We don't want to give false reassurance, but equally we don't want to make people feel they've definitely got cancer already. It doesn't mean that, okay? That's why they're having the diagnostic test. So some of the things, colonoscopy is a test that lets them actually look inside your bowels using a thin flexible tube with a tiny camera on the end. And what they're looking for is, they might see some lumps that look harmless. These are called polyps. And what they'll do is sometimes they'll just remove those during the test, and then they can still send it to the lab to look at. The main thing they're looking for is if they see a growth that looks like it might be something more serious, like worst case scenario, a cancer, that they'll take a piece of that, send it to the lab, they can examine it under a microscope, and it will tell them if it definitely is or isn't. And that's ultimately what they're trying to look for, okay? And in terms of the suspected cancer NICE guideline, it's NG12. A couple of recent changes, if we look at the last couple of years. So in 2023, the bowel cancer testing and referral guidelines were updated. That's the one we've covered in relating to this case. But in April 2025, the section on myeloma was updated. So they added in the Bence-Jones protein test, and the referral guidelines have been updated. So it's worth you revising that. And then in May this year, for esophageal and stomach cancer, so upper GI, urgent direct access endoscopy has been removed, and then the overall referral guidelines have had a slight tweak. So please go over that section. Okay. Right, in terms of MRCGP SCA support, for those of you that are going to do your exam soon, we've got lots of resources. So we've got our SCA casebook. So this was the first casebook with dedicated mark schemes for the SCA, which is different to both RCA and CSA. There's 400 pages, 75 cases. There's a full 12-case mock. We cover all the domains. We've had great feedback from it, and we've just published the second imprint. So we sold out the whole first imprint, and in September, so just last month, September 2025, we published the second imprint where we've updated, because there were several guidelines that changed since the first edition was published. So things like the asthma guidelines, menopause guidelines, so it's had significant updates. That's available now. We also have SCA cases online. It's those same cases, but as well as the cases, there's some consultation videos and additional material on sort of how to prepare for the SCA and how it's marked. We have our GP 100 case primer video, where a bit like how we've talked through a case today, we talk through 100 cases. And for each one, we'll go through the key things to think about in terms of history, red flags, symptoms, risk factors, examinations, how to make a diagnosis, what the current guidelines are for management, key things to think about in terms of interpersonal and communication skills. Every fifth case is an interactive case, just like today, with a simulator, and the audience are interacting with them. So it's 20 blocks of 5 cases. It's over 8.5 hours worth of videos. And this is useful as an update if you're already qualified and in practice, just to want to update yourself. It's useful when you're starting in GP and want to just get confident with how to deal with lots of different things. So we've got 100 different cases there, but it's also a really useful way to consolidate the knowledge base before your exam. Comes with a 362-page PDF course booklet. And these are the cases that are covered. And then our full day SCA intensive course, where in one day you'll see 20 live role plays. We have both a female and a male simulator, professional simulator, and you'll see the roles played. So everyone will have a go at an interactive case in the morning. They'll get some feedback. In the afternoon, everyone will do a full mock case with really detailed individual feedback, but you also get to see all the other doctors doing their roles, and you can learn lots from watching that and listening to their feedback. But there'll be 20 live cases that we go through in one day. The next live course is on the 16th of October. So just to summarize, look, remember, all 3 domains are assessed in every SCA case. So data gathering and diagnosis, clinical management and complexity, and relating to other interpersonal skills. So, in order to have time to do your management effectively, you need to be focused on your data gathering, trying to get that most of your data gathering done in the first half of the case, the first 6 minutes or so. Then it's going to take you a couple of minutes generally to explain a diagnosis, and that will then allow you at least 4 minutes to deal with management properly. Okay. Relating to others, the communication skills are assessed throughout the whole consultation, isn't it? Ultimately, once you've consolidated your knowledge base, it's about practice, because consulting well, both taking your clinical knowledge and being able to use it to take a focused history, to sort of use your time effectively, to pick up on cues and explore them, and communicating all of that clearly, those are skills, right? So you need a knowledge base, and then you need to practice to develop that skill. But the good news is, like any skill, if you prepare, you will improve, and if you prepare, you will succeed.